Good afternoon and welcome. My name is Carrie Craven, Administrative Specialist for KCMPA, and we are so glad that you were able to join us today. First off, we ask that while the webinar is in progress that you mute your phone to ensure that everyone can clearly hear the presentation. Please press *6 on your landline to mute, or you can use the mute button on your cell phones. If you have a question, you can ask it via the chat window in the GoToMeeting dashboard, and we will open it up at the end for questions as well. Joining me today is Jill Watson, who is CEO of KCMPA, and today she's going to give us a strategic update on KCMPA and what's been happening with us. So go ahead, Jill.
All right, thanks, Carrie. It has been a while since I've given the membership an update on where we are strategically. There's been kind of some big projects come to light here in the last couple of weeks, so I thought it might be a good time for us to check in. And just, you know, there's not enough opportunities out there for me to talk to the membership about where we're headed, and you know, there's so much information out there for you coming from every direction, not about KCMPA necessarily, but the whole rest of your business. I know it's hard to keep up on what we've got going, so this is my attempt to you know, bring everybody along. It's a good chance to ask questions if you want to do that. I'll try to leave enough time. I do have like 20 slides, so because I kind of wanted to cover everything all at once. So feel free to interrupt me during this if you want to talk about something while it's on the screen, or if you want to chat, put something in the chat box. I'll try to manage that too, or save your questions till the end would be fine also. So this is the November edition of our webinar series. We do this just about every month on some topic or another. Lately, they've been on some some care transformation topics like daily huddles and those kind of things. So this one is clearly non-clinical. It's just strategic about our organization. There's the last few, and the one I believe that might be coming up next month. So I want to talk today about some new member benefits that we have. I want to talk about our shared savings program, ACO. I want to talk about Comprehensive Primary Care Plus, which is a new program coming to Kansas City. I want to talk about the clinically integrated network that we are developing. And then a little bit about how I think all of those can relate to MIPS and MACRA for those of you who are beginning to think pretty seriously about that. So first, very quickly, we have a new group medical plan. It's been a long time in the making, like literally a career. So I'm pretty proud of that. I think it's a chance to save some real money, just good old-fashioned cost savings, which is a function of IPAs from way, way back. So if you're not aware of our group medical plan, please get informed about it. Carrie is the point person for KCMPA on that. And as your plans begin to renew later in 17, and there'll be opportunities for more practices to join that. So I hope you'll do that. It's capable of taking practices of all shapes and sizes. So there's a ton of flexibility, and would definitely be worth running at least a quote against what your current coverage is. The last bullet is just a little plug for medical liability insurance. We have a partnership with a specialty IPA called Spec KC that has some opportunities to save some dollars on medical liability insurance. I think that program is very competitive with the market. I know that medical liability insurance isn't a huge expense like it has been at other times in our careers, but nonetheless, it is possibly an opportunity to save some dollars going out there. So if you have questions about that, let me know, and I can connect you with the folks that handle that. So shared savings program, MSSP means Medicare Shared Savings Program. It's also called a Medicare ACO. I think a lot of people, when they say ACO, this is what they mean. So it goes by all those words. Back in 2012 when KCMPA was new. This was the newest program out there. It was, really the best tool we had available at the time to start getting into payment transformation. So we did do that. We were the first Medicare ACO in the Kansas City metropolitan area. We have learned a lot about population health and total cost of care contracts. This is well documented as well, but because our cost and utilization started low, it has been difficult to achieve shared savings in that program. That's a program where you try real hard for a year to reduce utilization and improve quality, and hope at the end of that time that maybe you have beat your benchmark or target that Medicare sets for you. And really the big payouts in the shared savings program have been in other parts of the country. So Kansas City is not really alone. They've been in other parts of the country like Florida and places where there have been, much higher utilization of Medicare services than here. And also in health system owned ACOs, so where all the providers are owned by a single health system, usually on a single EMR, have the processes all down and can control everything. It also helps if they're now possibly a sole provider in a market. So that's not the case for KCMPA in the Kansas City market, and our experience hasn't been one where that program has brought us a lot of dollars. So now fast forward 4 years, we have a new program available to us now called CPC Plus. I guess I should back up a little bit on the Medicare ACO. Regardless of the fact that we haven't saved big dollars and didn't return money to the clinics that were involved in it, we renewed that program for a second contract year just because we knew there's more we could learn on total cost of care from the claims that we get from that program. So even though there weren't shared savings coming from that, we had managed to keep our costs low enough that we could stay in that program, still continue to learn about the transformation to value-based care, and to continue to participate in that program. So fast forward to now, which is where we are with CPC Plus. Kansas City is one of only 14 markets in the nation that have CPC Plus. And honestly, CPC Plus is a far better financial model for KCMPA clinics who are KCMPA members than MSSP. So where MSSP offered funding after care coordination was provided and savings was achieved, CPC Plus provides cash up front to put that robust care coordination in place. So all of you who are running practices know that margins are small. You don't have a lot of cash laying around to add on new and different things that you weren't doing last year. And so the prospect of cash up front is very appealing, far better than what MSSP is offering currently. That's funding that continues for 5 years as long as quality continues to stay high or improve. So how do the two fit together? So technically, clinics could stay in both the Medicare Shared Savings Program and CPC Plus, but staying in both programs doesn't make sense for KCMPA clinics because the reason why you would stay in both is because you thought you are likely using your care coordination tactics, whatever they may be, are likely to get shared savings that would be over and above what CPC Plus offers. That's not the case in Kansas City and not the case with KCMPA ACO. So in reality, a clinic would have to forego some of the financial incentives in CPC Plus if it stayed in an MSSP. That's significant when you start thinking about MACRA and MIPS. CPC Plus is considered an advanced alternative payment model. which could potentially qualify providers for the 5% lump sum bonus. Our Track 1 MSSP does not qualify us for that, and it's not likely that we would go to a higher risk track in that model because, honestly, we don't have a real pathway to savings. So taking on risk in a contract where you don't see pathway to savings is essentially signing up to write the federal government a check. And I can't in good conscience have our board do that. And I don't think we could get many participants to sign up knowing that would be the likely outcome. So all but one KCMPA primary care clinic will exit our shared savings program ACO in anticipation of being selected to CPC Plus. So exiting the shared savings program doesn't mean they leave KCMPA or that they're no longer part of our team. It just means they're not in that contract. So they're going to move to CPC Plus contract, which KCMPA also will be supporting. Anyway, I want to tell you what does exiting the MSSP program mean and for that contract, but also for the rest of our APA. So the number of clinics participating in KCMPA is not going to change at all, or very little. So it just means they won't be participating in that Medicare shared savings program contract. So regardless of that, KCMPA will remain in the shared savings program for 2017, even if we have fewer than the required 5,000 beneficiaries. So the number of clinics that have asked to exit the program in anticipation of being selected to CPC Plus means that we likely will fall below the 5,000 beneficiaries that you're required to have in order to participate. But CMS will give ACOs and will give KCMPA a year to try to get that number back up. And we will use that year to determine whether or not we want to stay in that program long term. That will give us time to see if there are very many clinics that are not selected to CPC Plus, or if we have interest in adding new clinics that didn't get into CPC Plus, or if there are a significant number of specialty clinics that want to get into a shared savings program ACO because that might give them favorable treatment in MIPS or MACRA. That allows us another, essentially at least 9 to 10 months to think about that and make those kind of evaluations. So that's some nice flexibility. And KCMPA ACO will continue to be a recognized shared savings program participant by the government. So nothing, will change about that status either. Next, I'll talk about clinically integrated networks. So looking at who's on the call here, I think most of you are familiar with these, with this term, clinically integrated network. It's largely been driven by hospitals recognizing that they need to partner with physicians in order to be successful into the future in value-based contracts. A clinically integrated network, as it says on the slide, brings hospitals and health systems and physicians together to transform care, share technology, share performance benchmarks, and data, trying to deliver a different kind of patient experience. Our CIN will be physician-led and patient-centered. I have been struck by the intensity with which that statement is shared at all the CIN development and assessment meetings that I've attended. The consultants that are hired by the health systems to advise them on development of a CIN are very abundantly clear that independent physicians must be part of this and must have really a disproportionate leadership role in it in order to get to a position where we would all want to be, that would allow joint contracting and collective negotiation on those contracts. So that very much is is part of the plan, which is a great opportunity for independent doctors, which feel, you know, relatively powerless at this point, I think, on their own in their conversations with systems or any kind of a bigger entity. So I think this is a nice opportunity for independent physicians through KCMPA to get a little more influence than we might be able to get all on our own. Of course, they're looking to partner with physicians who get what we're trying to do and want to move in that direction. So I feel pretty good that most KCMPA practices have been through that discussion philosophically and are ready to move in that direction. Let's see here. So why would KCMPA be part of developing a CIN? I mentioned a little bit of that, but I want to say it again, that we want to be well positioned to respond to changes in healthcare. We want to be able to frame the discussion about care and payment transformation. I've worked for physicians just about my entire career, and I still believe that they are the best qualified to determine how we can provide the best quality care at the least cost. And this sets us up to be able to do this. It will allow us to share the expense of establishing population health management expertise. We've gotten into that somewhat in our Medicare Shared Savings Program, but it doesn't take long to realize that to really do this, you know, practice-wide and for all patients, not just Medicare patients, you have to be able to scale it. You need more of everything, and all of that costs money, which, you know, physicians don't have and are looking for help in financing those kind of things. It will help us maintain influence over practice models. KCMPA physicians have, and I think always will be, independent. And this is an opportunity to stay viable in your independent model. I think it gives us pieces of the stability and the support and resources of a larger networks without having the constraints of an employment contract. So kind of hopefully best of both worlds. And then like negotiation with commercial payers and self-funded employers and thriving in value-based payment. So who's involved? These are the entities that are involved in this discussion. Somebody want to make a comment? Okay. So I don't know if my pointer is showing up here, but most of our discussion has been involved with everyone on the right side of the slide. Stormont Vail came in most recently, and of course they're looking for really a relationship with the Kansas providers in particular, but also, you know, KU in specific. So as we get more into the description of what that'll look like, you'll see that most of our work will probably be involved still with just the folks that are the most active in our local medical training area here in Kansas City. So there have been literally years of assessment of the feasibility of a network made up of these providers. Lots of consultants discussing what's the feasibility of all of them working together, you know, what's the impact on the market. Together, they represent about 24% of the healthcare market in Kansas City, which is a nice chunk, certainly enough to get the attention of large employers and folks looking to do narrow network potentially. Already all share together the Blue Cross Blue Shield patient-centered medical home pilot, so we can easily aggregate that data together and as part of our trek towards clinical integration. All these hospitals are also subject to CJR bundle payments for hips and knees. So we've got that in common, and those metrics that can be shared and compared. And then there are 3 Medicare ACOs as I just discussed ours. We have one, KU has one with their Jayhawk physicians, and Stormont Vale has an ACO as well.
I'm sorry, Jill, I want to stop you for just a second. I'm hearing a lot of paper rustling and a lot of background noise. So if you would all please make sure your lines are muted so that we can clearly hear Jill's presentation, that would be great.
Okay, thank you for that. Why is KCMPA involved with hospitals? I've worked with doctors, again, most of my career, and I know that there is some tendency of independent practices to want to do this entirely alone without any hospital involvement. There's a couple reasons why I just don't think that's realistic right now in Kansas City. It may be in the future as more physicians, swing out of employment arrangements. But the fact is you can't get, cradle to grave care provided in independent settings. So at some point, your patients are going to have to go to a facility-owned practice, certainly into an inpatient facility to get care. So I know there are some markets where independent physicians are doing this all on their own. And, maybe Kansas City will get to that one day, but, I'm looking around at what is doable today. And today, I don't see that independent physicians doing that without some kind of a partner. You can pick your partner. It can be hospitals where you have patients go and you may not like everything they do, but you're familiar with them. It could be venture capital. It could be providers that you haven't met before. I guess there are options, but unless providers want to pay the full bill, and I don't see that we do, this is I think the most tenable option. So as I mentioned earlier, we realized very early on that our success in a total cost of care contract, which is what the MSSP program is, will require collaboration with inpatient and post-acute providers. Those of you who've been around for a while might remember we had a congestive heart failure home health diuretic protocol that we were just trying to get it ordered from an inpatient setting so it could be activated in the outpatient setting. And even that, small, in quotations, process, it's very hard to get something ordered out of an inpatient system. Is no small deal. To have some alignment around more than just this one protocol is going to be far more effective going forward. I mentioned that transformation and taking risk take money that physicians don't have, and health systems do have money, at least for now. And these particular systems were already exploring alignment together. Many of them have been very supportive of KCMPA in specific and independent physicians for years. I know in all the years I've worked in Kansas City, North Kansas City has been a great partner of the physicians who work up there. Most physicians speak very highly of that facility. So, and they have a giant leadership role in this deal. So I think independent hospitals, or ones that act independent, like Shawnee Mission does in our market, they're part of a bigger system. I recognize with Adventist, but in this market, they act like just one single hospital. And so I think those kinds of hospitals are feeling vulnerable now too, as just like independent physicians are, independent practices are, that against bigger systems, they're feeling like they need to align as well in order to continue to be viable with commercial payers and with what employers are wanting to buy, either on the self-insured market or from a payer if they are still have a fully insured plan. So that's why we're working with hospitals at all. some KCMPA specific consideration. KCMPA is a partner versus is a participant, not a capital partner, because as you might expect, a capital partner requires capital, and that's not something that we have. So without making a cash call to all of our members, which we didn't feel like would probably be super popular. So we chose to be a participant, not an owner. It was extended to us, but we did not accept an ownership of the CIN. KCMPA leadership on the physician, PLC means Physician Leadership Committee, and I'll show you some diagrams of what these all look like. But we actually have a disproportionate share. We have eight physicians that we've asked to be on the Physician Leadership Committee. And I think there's like 8 other physicians in all the systems combined. So that is, I guess, hopefully fulfilling all the promise and the potential of a real physician-led CIN. So I'm very pleased about that, and I'm hopeful that continues to be a good, relationship activity. We will be very involved in the quality program development. Physicians naturally will gravitate there. That's one of the places that is likely to get activity sooner rather than later. And so I expect that quality program to start moving fairly quickly. It's designed that KCMPA will be the vehicle for independent physicians to access this CIN. So that will be good for KCMPA as well as we gather more and more independent groups under one IPA. It'll be helpful for this initiative, but it'll be also helpful for other initiatives that might come up and have some viability in the Kansas City market. So I think it'll be helpful to have a lot of independent physicians working together. Our plan is to offload the expense of the population health infrastructure that we have built, so that KCMPA retains a lean and low expenses that the physicians can support long term, but still gives the physicians access to all the services of our staff and our expertise and that we've built as KCMPA. And again, I think there's some slides later that talk about that. I mentioned that our health plan, that will continue to be provided. We are working on an enhancement of the Blue Cross Blue Shield PCMH network. That would be a value-based agreement on top of what Blue Cross is offering each of your groups through the PCMH network. So stay tuned on that as well. Of course, CPC Plus and MIPS and MACRA, as folks transfer or transition to CPC Plus or get prepared to report under MIPS and MACRA. There are services that will be available and more robust than KCMPA has been able to put together on our own to support reporting and quality improvement, all those things that we need to be working on to continue to do well in the Medicare program. So the organizational model includes 3 parts. One is sort of a super CIN that would be where the quality program is kind of developed, or where the principles are agreed upon. But then most of the activity is going to happen in the shared population health services entity and in the regional CINs. I mentioned earlier on when I had the logos on the screen that most of our activity would be with North Kansas City, Shawnee Mission, and KU and KCMPA. And so that's where contracting opportunities are likely to come. We've already been reaching out to all the commercial payers. They're well aware that this entity is in development, and I expect that we'll have new kind of contracting opportunities in the early part of 2017 to consider. So for the time being, starting this out, this is kind of what the development organization and committees will look like. The two at the top there are an executive leadership council and then a physician leadership council. I mentioned the physician leadership group earlier. This is the one that KCMPA has a majority of physicians selected to it. So certainly has the most opportunity to be influential there if we take it. The Executive Leadership Council are health system administrators, myself, I am on that as well. And so recommendations from the work groups will come up to those two groups for some decision making here in the in the next year. I think those you can expect the decisions to be made in this kind of a process. And then there are 4 work groups underneath. We also have folks that are will be working on each of those work groups. One is on organization and governance, where our attorney Mark Flaherty will sit on that group with the other attorneys from the other entities as well. Communication and network development. That's a committee that I'll spend some time on, and we have some others from KCMPA practices that will be working on that group as well. Same with payment transformation and finance. I think that will be a group where most of the contract discussions come, and I think those early on will be with commercial payers. That's where most of the action is in Kansas City and the size of market that we are. We have had interest from employer groups, but I expect those to take a little longer to develop. So we'll see. And then clinical quality and IT go together because the quality measures need to be supported by the IT to pull to gather the data and report it back to whoever we need to report it to. So I expect there'll be a lot of physician input on that group. Not necessarily in the work group meetings, but certainly when those recommendations get up to the Physician Leadership Council. Cindy Campbell from KCMPA will be on there from a quality perspective as well. So, and there are others from KCMPA practices that will be on there too. So we will have some input there. Longer term, this is what kind of after the development process happens, this is what the governance structure is likely to look like. So I'll just let you take that in. This Kansas City, this is where most of our activity is going to be focused, but certainly, this work matters as well as we look at, quality programs and overall care transformation between the many entities that are there. And this is how we move from the first phase to the second. So folks from these will likely seed the boards of managers, so including the physicians. So if our physicians have an interest in taking long-term leadership positions, I think they'll have an opportunity to do that. And certainly work group participation will continue in the form of these committees, long after this development, we move from development to operations. This just talks a little bit more about, who participates in each place. Again, the Population Health Services doesn't have KCMPA as a box here, but this is where KCMPA's expertise will be in the form of staff and those kind of things. So you probably need to have a box added for no other reason than that there. So I'll work to do that. This kind of tells you which, over here, obviously Kansas entities are most interested in the Kansas, statewide, CINs and that we are in the metro area here. And these blue boxes or ovals down the side really talk about contracts that exist now that we can start to consider together, including CPC Plus, our shared savings program, ACOs, I mentioned the Blue Cross PCMH network, and then other commercial value-based contracts. We are already in discussion, as I said, with Blue Cross about you know, an additional value-based level on top of their PCMH network that would have us looking at performance as a group rather than as individual practices, with some additional possibility for income for that performance. So here's a timeline. This is probably getting into your lunch hour now here. Sorry to take so much time here, but this is the timeline. I won't run through this, but in detail, but basically here's where we are now. The first meeting of all the work groups, including the Executive Leadership Committee and the Physician Leadership Committee, is December 1st. And for those of you who didn't understand at the last board meeting, but we've decided that our best chance for getting KCMPA physician involvement is to keep those meetings on the same time, on the same day as our KCMPA meetings, which our members have had blocked for the most part for a long time. And so rather than ask them to carve out yet another evening, that we would combine them onto the same evening. And so that's our plan. I hope that everyone is excited about that decision and not thinking they'd rather have another night to be away from their families. But I think that's a good call for us. We will continue to still have KCMPA board meetings on the same evening. I think folks can mostly call in for those. We'll try to keep those very brief, a lot of written reports. And again, this is temporary until the final board of managers and all is transitioned. So you know, this isn't a forever thing that we're going to do this, but we're going to, you know, give our physicians the best chance they have over the next 6 to 8 months to have the most influence over the development of the CIN. So that's what we'll be doing. We'll have entities by the end of the year, 1st of January, and begin working on participation agreements. There will be a process where each of our groups will have to consider and sign a participation agreement. I didn't mention in my slides, but I should have, that this is a non-exclusive deal. So most CINs are, and so this is a non-exclusive deal. You can be in other clinically integrated networks if you want to. So there isn't any reason that you wouldn't want to be in one from that perspective, because you are not, you know, cutting yourself off from any other opportunities that you might know of that could be coming in the future in Kansas City. So probably announce a name. I keep calling it the CIN, our CIN. It will have another name, which I don't know what it is yet. There's all that stuff has to run through trademarks, and it's very difficult to name a healthcare entity, harder than you'd think. So that's in process, and I will certainly let everybody know once we have a name. I'll be very excited to be able to call it something other than the CIN. And then our hope is that we would go to meet with the Federal Trade Commission. I know the health systems and certainly the independent providers, some of which have had some experience with the FTC in their careers, are not interested in getting in any kind of trouble or sideways, you know, with the government in this arrangement. And, you know, we're certainly not interested in that either. And so our plan is that we would build something that we could take to the FTC and give them a chance to object to anything that's going on. And then I think the way it goes is, by virtue of no objections, it's considered to be, you know, okay. So we'll do that sometime in this, or, you know, early summer, hopefully. Any questions on any of that timeline? I'll be happy to talk about them, but I'll keep moving on here. Then MIPS and MACRA. So all this relates back to MIPS and MACRA. CPC Plus takes the primary care docs that are selected to be part of CPC Plus are taken out of MIPS and MACRA entirely. CPC Plus, as I mentioned earlier, is a track, it's an advanced alternative payment mechanism. So they are not subject to MIPS and MACRA. Everybody else will be. And the data aggregation and quality reporting and care management support that KCMPA has developed through our shared savings program are all transferable to MIPS and MACRA. So we could help practices aggregate data and report it. Excuse me, I had to cough. The care management, the dietitian, the clinical pharmacy, all of that will continue to be available and could assist in improving your quality measures for MIPS. So that's the plan. The KCMPA staff, services, practice transformation expertise, and all of that will reside in the new PHSO so that our relationships are all still available. That expertise isn't lost to KCMPA. So specialists and PCPs that are not in CPC Plus or any other Medicare or ACO can utilize these services for their MIPS responsibilities. Our shared savings program, Track 1 ACO, will still exist for those practices that want to get favorable treatment offered by MIPS. As I mentioned earlier when I was talking about the shared savings program ACO, there's several other considerations, but it will remain a vehicle that we can have, kind of at our disposal while we figure out what's the best configuration for all the KCMPA members. KCMPA's future, KCMPA is going to continue as an IPA long into the future. It will continue to be owned and governed by independent physicians. Us being part of a CIN is not a merger or an acquisition of KCMPA of any kind. In fact, KCMPA must stay strong in order for our physicians to really get the influence that we want them to have in the CIN. I mentioned, I think, that it's likely to grow. More groups are likely to join KCMPA, especially when we start to look at commercial contracts. Our group benefit plan will continue to be offered, and in fact, we'll look for other opportunities to cut costs on the business side of your practices to any extent that we can. So KCMPA, as I said, will be a participant in this SIN. It would be free to be participants in other SINs, and certainly our KCMPA members would be free to be participants in other CINs if there are some that become active that you want to be part of. And KCMPA then will be able to consider other alignment opportunities as they present themselves, just as we have up to this time. And so all of that still stays, regardless of what government programs exist or what CINs exist or any of that. So I hope that answers some questions and makes some things clear. I think KCMPA has a firm position as an ACO in Kansas City's market. CPC Plus and ACOs are complementary. It's not that we've decided the ACO didn't work, so we're going in another direction. It's just an evolution of the strategy, really, using, again, tools that are available in our market. So KCMPA will continue to have ACO contracts, whether they're with commercial payers or the government or whoever through our SIN. So we remain committed to helping independent practices succeed. Nothing about that is changing, and we'll continue to do that with whatever tools exist, as the slide says. The ones that we know and I've talked about today, and probably things that we haven't even heard of yet. So hopefully that's helpful to you all. I'll just go back to that one so you're screen's not black. But if there are questions, I would be happy to answer them. Steve Best made a comment about direct to employer. Steve, is it okay if I read this? I have it out loud.
Yeah, you can go ahead and read it, Jill.
Okay, so Steve says, I doubt there would be enough self-insured employers with large KC-only employees that would make negotiating with them directly valuable. I'd concentrate on commercial payers, which employers like J.E. Dunn use for their nationwide networks first, and then go to employers directly if that doesn't seem to be getting traction. And I think you're totally right. I think you're totally right, Steve. That's our plan. We have a good relationship with Blue Cross. You know, the bigger national players don't have as much interest in Kansas City, but they certainly do when we can start talking about multi-state employers and like the ones that you're talking about. So we are pursuing those discussions with Aetna and Cigna and United. I had a meeting yesterday with an entity in Dallas that's doing similar to what we're doing, and they have relationship with airlines and folks like that you know, likely that I think those things are just going to continue to evolve that way. So any other questions or comments about any of this from anybody who's still on the phone? Well, I'll take that as that I was very thorough and you have nothing you want to ask about this. If you think of something offline or if you don't want to talk about it in front of other practices, please give me a call or send me an email and I'd be happy to talk with you about your practice in particular. You know, I'm happy to do that. My phone number is 816-456-7924 if you want to call me and you don't want to look it up. If there are no questions or any other comments, I think we can let you go to get on with the rest of your day. Carrie, is there anything that you wanted to add before we hang up?
No, I think we're good. Thank you so much, everyone, for joining us today.
Thank you, Jill.
Thank you.